Hello and welcome back to Pathognomonic Immunology, where in this lecture, having already gone over all the basic science you have to know for the boards, we'll focus more on the clinically relevant aspects of immunology. And you're likely to get the majority of your immunology questions, even some basic science ones, in the context of a clinical vignette, which makes this entire lecture pretty high yield. We'll first cover certain concepts they like to test regarding vaccination, talk a lot about the four main categories of hypersensitivity with examples of each, and then talk about what can happen if the body encounters foreign antigen in the form of transfusion or transplant. Before we can discuss vaccines, we need to talk about the concept of passive versus active immunity. Passive immunity basically just means that the body receives pre-formed antibody passively from an outside source. This requires no effort by the body, as would ramping up its own adaptive immune system. The plus side of receiving antibody is that it's ready to go and works quickly. The adaptive immune system takes a little bit of time to kick in, and sometimes we don't have time to wait around when we are trying to combat certain infections. However, these antibodies have a relatively short lifespan and a half-life of only a few weeks. It's really a temporary band-aid until the body can make antibody for itself. The most common example of where preformed antibody can help is the maternal antibody that newborns get from breast milk. Babies' adaptive systems aren't fully mature until around 6 months. Until that time, newborns can use maternal IgG antibody that cross the placenta in utero and whatever IgA they get from nursing. This is part of why clinicians' minimum recommended amount of time to breastfeed is 6 months, and also why some humoral immunodeficiencies don't manifest until 6 months of age. Like we mentioned, we also give antibody to patients when we don't have time to wait for adaptive immunity to kick in. Antibody can be used to bind dangerous infectious toxins, such as tetanus and botulinum. This was actually first done with diphtheria, where they would take preformed antibody from animals that have had the disease to help bind the toxin causing it in humans. The same tactic is employed when we give gamma globulin shots, or IVIG, to patients infected with certain pathogens if they had no prior vaccination or no known history. Rabies can progress very quickly to death and is a common example of where we'll give IVIG together with vaccination to people with even potential exposure to bats and other animals known to carry the virus. And this is also done for people exposed to Hep B. Synthetic monoclonal antibodies that target specific antigens to help the body fight some cancers can also be seen as passive immunity. On the flip side, active immunity is when the body is actively making its own antibody in response to an antigen, even if that antigen is administered artificially in the form of a vaccine. Obviously, since the body's adaptive system must be activated, this takes longer, but it also leads to longer-lasting protection because the source of antibody is the body itself, which means there will be memory cells activated even if re-exposure happens much later on. We have spent much of the first few lectures in this series talking about how infection leads to immunity, and that is of course an active process. But like we just mentioned, vaccines and toxoids can be given to mimic disease and activate a humoral and/or cellular response without actually causing the disease. A toxoid is a synthetic protein, biochemically engineered to resemble a pathogenic toxin and elicit an immune response. These are sometimes used as conjugates in vaccines for other bacteria in order to elicit a T-cell response. As in the case of rabies or Hep B, it's never too late to vaccinate, and we combine passive and active immunization in post-exposure prophylaxis. We'll give some antibody to tide the patient over until the body's own response kicks in, but we also vaccinate, so once the antibody wears off, the body is better prepared to fight on its own. When someone has not yet encountered antigen, the body will not have a ready response to it. However, in modern medicine, we can simulate the effect of immunity through vaccination, and the response you get depends on the type of antigen used. A thymus-independent antigen is really just a backward way of saying T-cell independent antigen, because as we know, T-cells mature in the thymus. With these antigens, T-cells are not involved because they lack a peptide component, and therefore cannot be presented by MHC to trigger a T-cell response. An example of this would be something like LPS, which is a polysaccharide, and these antigens are more weakly immunogenic. A vaccine without a protein component therefore leads to a shorter lasting response, and a subsequent vaccine or booster is necessary to keep immunity going. Another way around this is to include an adjuvant. An adjuvant is something added to a vaccine to help the adaptive immune system become activated in a more targeted way, and this is sometimes a bacterial product or toxoid. Conversely, a thymus-dependent antigen has a protein component, which means T cells will be activated as a result. And we know T cells are necessary for B cell class switching, so we get a stronger IgG response. And T cells are also needed for memory cells to be created, so the immune response to foreign protein is much longer lasting. There's a high-yield example that they really like to test this concept on, and that's the difference between the vaccines available for prophylaxis against pneumonia. The pneumococcal polysaccharide vaccine, PPV-23, commonly known as Pneumovax, is given to adults 65 and older and people with COPD, diabetes, and contains only polysaccharide. This means it induces a relatively weak antibody response, but it covers the 23 most common strains of strep pneumo. The pneumococcal conjugate vaccine, PCV-13, which is marketed as Prevnar, covers fewer strains but is recommended for kids that require pneumococcal prophylaxis because they are immunocompromised or asplenic and won't mount enough of a response to the polysaccharide. It's a conjugate vaccine because it's covalently bound to an immunogenic protein, which in this case comes from diphtheria. It's actually now recommended adults get this too if they've never received it. Let's quickly go through the different types of vaccines and the pros and cons you have to know about each one. Live attenuated vaccines are live, so they are capable of limited growth, but they are also attenuated, meaning most virulent aspects of the pathogen have been subdued, and so they are not pathogenic. This type of vaccine has the strongest immune response because it's the closest thing to being infected. It will lead to both cell-mediated immunity as well as a strong humoral response that can last a lifetime. The obvious downside is that we're playing with fire somewhat, and these vaccines have the greatest chance of reverting to virulence. These vaccines are therefore contraindicated in anyone even relatively immunocompromised, such as pregnant women, and the common example of a live vaccine is the MMRV for measles, mumps, rubella, and varicella. Important to note that HIV patients that have not yet progressed to AIDS and have a CD4 count above 200 can receive live vaccines. A killed or inactivated vaccine is one that has pathogenic parts that are inactivated by exposure to heat and chemicals, but these will still work to induce immunity as long as the epitope structure on surface antigens is maintained. It's important to know that killed vaccines only induce a humoral response as B cells can undergo T cell independent activation, but to elicit a cellular response necessary to fight intracellular pathogens, cells must be infected and antigen presented on MHC. This obviously can't happen if a pathogen has been completely inactivated. An example of this is the flu injectable vaccine, which induces neutralizing antibodies to be formed against viral attachment proteins. If there was a cell-mediated response, cytotoxic T cells could actually target infected cells. The fact that T cells are not involved means that there is no long-term memory induced, and these vaccines usually require a booster, but they are also theoretically safer. Subunit vaccines are vaccines designed to contain only the most immunogenic antigens. There are less side effects, but there is always the trade-off of having a weaker immune response, and in practice, these are expensive to make. They're reserved for pathogens that we want a lasting immunity to, but that we still want to be able to give to immunocompromised patients, and some examples are the pneumococcal HPV and hepatitis B vaccines. Toxoid vaccines include some kind of denatured bacterial toxin, usually tetanus or diphtheria, which stimulates production of neutralizing antibodies. If you remember from our last lecture, one of the major functions of antibody is to surround viruses and toxins and prevent them from being able to attach to cells, and this is called neutralization. Since the toxin is not active, there is no potential for disease, and toxoids are added to many bacterial vaccines. We already discussed the pneumococcal conjugate vaccine, but other good ones to know are the Hib vaccine for Haemophilus influenzae and the acellular pertussis vaccine for whooping cough given as part of DTaP. The levels of antibody tend to decrease over time though, and this is why we get Tdap boosters. Now let's get into a very high-yield topic, the different classifications of hypersensitivities. I'm not sure why we care so much about the arbitrary classification of things, but we do, and they love testing which parts of the immune system are at work in different kinds of situations. When we think of immune hypersensitivity, we generally think allergic reactions, which is just a subclass. Hypersensitivity can refer to any of 4 types of exaggerated responses, which makes it an easy boards question to write because you'll usually have at least 4 choices. There's a mnemonic to remember the names of each type of hypersensitivity that correlates pretty well. That is A, B, C, D. The A is for allergy/atopy or anaphylaxis and a strong allergic response. This is type 1 or immediate hypersensitivity and involves mast cells. But to get an allergy response, someone first has to be pre-sensitized by antigen and form IgE antibody. Type 2 hypersensitivity is a B-cell response carried out by antibody directly, and this classification is probably the broadest in its application. Since antibody has several different roles, there can be many manifestations of type 2 hypersensitivity, and we'll talk about those. Type 3 goes with C for immune complex deposition, and these complexes are comprised of antibody bound to antigen. Types 2 and 3 both involve antibody and tend to be the most commonly confused, so we'll talk about how to distinguish between them. And lastly, type 4 is D for delayed, and the reason it's delayed is because it involves T-cell activation and cell-mediated immunity. Even without this mnemonic, it's not too difficult to see that each type adds a new layer of complexity. Type 1 involves the innate system, type 2 is based on humoral immunity, type 3 involves antibody already complex to antigen, and type 4 involves a T-cell mediated response. So let's get down to it. Type 1 hypersensitivity has two phases. The first is called the immediate phase, which takes place within minutes of exposure. And we've already gone over this high-yield mechanism in detail in our innate immunity lecture. This is when allergen cross-links the IgE on pre-sensitized mast cells, leading to release of histamine. Histamine is responsible for smooth muscle contraction that leads to vasodilation, causing erythema, warmth, and swelling, and also to bronchospasm, which is what causes airway problems and severe reactions. We give antihistamines like Benadryl to treat allergy. The second phase is the late phase, which happens not too much later, but can take a few hours. You should not mix up these phases with the terms immediate and delayed hypersensitivity. Immediate hypersensitivity, confusingly, refers to the entire type 1 response, and includes both of these phases. And as we've touched on, delayed is type 4, a T-cell response. So in the late phase of immediate hypersensitivity, mast cells continue to release cytokines such as leukotrienes and prostaglandins, which have similar effects to histamine and lead to more inflammation. Certain ones like leukotriene B4 are chemoattractants and bring in other inflammatory cells that cause tissue damage like neutrophils and of course in an allergy response, eosinophils. In asthma especially, bronchoconstriction is due to prostaglandins, and these also attract many eosinophils into the lung. Common examples of type 1 hypersensitivity are things like seasonal allergies to grass or pollen, pet allergies, or some people are allergic to mold, but these are usually not that severe. The ones that may show up on your test are allergic reactions to food that cause hives and potentially airway compromise and anaphylaxis. For some reason, peanuts and shellfish have become major allergy triggers in society. And many people also make IgE antibody in large quantities instead of IgG to insect toxins, and after a second exposure can have a major reaction. And many drug reactions are allergic in nature as well. A common offender is penicillin and other beta-lactams. On the boards to hint to immediate hypersensitivity, they will usually include a description or show you a picture of hives, which are due to histamine and can be recognized by their classic wheel and flare appearance. They will be distinct plaque-like areas of swelling and erythema, slightly more pale at the center, and with an erythematous flare reaction in the immediate surrounding area, and this is all due to vasodilation. Vasodilation is also to blame for allergic rhinitis and conjunctivitis, which present as a lot of leaking fluid. Having a runny nose and eyes that also itch causes many kids with chronic allergy to appear with the classic allergic salute crease on their nose and allergic shiners from rubbing their eyes and nose so much. But more severe reactions present with facial swelling, difficulty swallowing due to laryngeal edema, shortness of breath, wheezing, and frank anaphylaxis. Antihistamines won't be enough. Epinephrine is needed for bronchodilation and to raise the blood pressure. Atopy is kind of an allergic syndrome of sorts, which tends to be familial. These kids will be allergic to all kinds of food like milk, eggs, and nuts, and will have to carry around EpiPens in case of exposure that can happen at any time. There is a strong association with allergic rhinitis and eczema, also called atopic dermatitis, and as babies, they will constantly be slathered in soothing emollients. Kids with atopic tendencies have an increased likelihood of developing asthma as well. To test for allergies, usually we start off with skin testing, where we introduce an allergen by lightly scratching a small sample of it into the skin and looking for that wheel and flare reaction. That tells us that there is IgE antibody being made against it. A less cumbersome test, for the patient at least, is the ELISA, which is essentially a blood test for antibody. Type 2 hypersensitivity is, like we said, caused by antibody, but type 3 hypersensitivities also involve antibody, which can make things confusing, so pay close attention to some key words here. Type 2 hypersensitivity, by definition, means that antibody is binding surface antigen in tissues, directly leading to inflammation and cellular destruction. So how do antibodies cause cell destruction? Well, there are a few different mechanisms. Firstly, antibody can opsonize cells, which make them prime targets for phagocytosis by macrophages, or ADCC by natural killer cells. This form of type 2 reaction generally happens in the blood, and examples include autoimmune hemolytic anemia, or ITP, immune thrombocytopenia, where the body's own red blood cells and platelets get opsonized by self-reactive antibody. They then get removed from circulation by innate cells in the reticuloendothelial system. These include splenic macrophages and liver Kupffer cells. These reactions are not always autoimmune though, and the same thing can happen in response to foreign cells in a transfusion or in hemolytic disease of the newborn, where mom makes antibodies against fetal blood antigen. The test for this is the Coombs test, and there are two ways this can be done depending on the scenario. In a direct Coombs, you are asking the question, is there hemolysis already taking place? And you would do this if a patient has anemia and you suspect an autoimmune process as the cause. So a blood sample will be taken from the patient and the red blood cells will be incubated with anti-human globulin, aka the Coombs reagent, which is essentially IgG that binds the Fc portion of IgG. This is meant to detect antibody already bound to red blood cell surfaces and will cause red blood cell agglutination, or clumping together, that causes red blood cells to precipitate out in a positive test. On the other hand, you would do an indirect Coombs test prior to any hemolysis taking place because you are asking, does this person make antibodies against the cells that are about to be introduced? Meaning, have they had prior exposure to this antigen, and would they hemolyze red blood cells if exposed again? You would do this to test pregnant women in the prepartum period to screen for ABO incompatibility, or if she is Rh negative to see if she makes anti-D antibody. This is also done in a type-in screen to test patient blood prior to a transfusion and avoid reactions. The way the indirect test is done is more indirectly. Serum is taken from the patient and then incubated with red blood cells of known antigenicity, representing the donor blood. If the patient does make antibodies against those antigens, they will bind the red blood cells. The Coombs reagent is then added, and again, if the antibody has bound the red blood cells, there will be agglutination. You can remember this is the indirect test because there's an additional step. Let's go to a schematic for a second to illustrate this. In a direct Coombs test, you start with the patient's red blood cells, which you suspect may already be under attack by antibody. You add the Coombs reagent, and if the red cells you are testing are indeed covered in antibody, the Coombs antibody, each of which has two antigen binding regions, will join multiple red blood cells together, causing clumping. In an indirect Coombs test, there's an additional step. We are looking for antibody in the patient's serum, so we start with the serum, and then add red blood cells containing the antigen we suspect the patient may be making antibody against. If they are making antibody against that antigen, it will be present in the serum, and when the serum is mixed with the test blood, the red blood cells will be coated. To visualize this, we add the Coombs reagent, and once again, agglutination indicates a positive result, that the patient has antibody against the suspected antigen. Getting back to the manifestations of type 2 hypersensitivity, remember that a second function of antibody is complement fixation, leading to activation of the classical complement pathway. Again, it is antibody binding that's directly responsible for inflammation in this case, so it's a type 2 hypersensitivity. Here are some examples. In Goodpasture syndrome, antibodies attack the basement membrane in both lung and kidney cells. This causes tissue destruction by way of complement and results in hemoptysis and hematuria. In rheumatic fever, a complication of infection with group A strep, antibodies that are made against the strep M protein cross-react with self-antigen in the heart, leading to mitral valve damage. And hyperacute transplant rejection also involves antibody-induced destruction by complement, as we'll discuss coming up later in this lecture. Another reason why the manifestations of type 2 hypersensitivity are so varied is because aside from the normal functions of antibody, in certain autoimmune diseases, antibodies can bind to receptors and cause disease that way by changing the way the receptor functions. An antibody binding can either be as an antagonist, causing a loss of receptor function, or it can be an agonist, acting like the receptor ligand and cause hyperfunction. And we have examples of both. In myasthenia gravis, autoantibodies bind to and block the postsynaptic acetylcholine receptor on muscle, which results in weakness. In Graves' disease, thyroid-stimulating IgG antibodies bind to and stimulate TSH receptors, causing hyperthyroidism. There are many variations of how type 2 hypersensitivity can manifest, which makes it confusing to learn. If you remember the theme that it's a direct effect of antibody binding that causes the pathology, you'll be in good shape. Let's contrast this to type 3 hypersensitivities and you'll see a clear difference. Type 3 reactions are due to antigen-antibody complexes depositing in tissues and triggering complement-mediated tissue destruction, and also attracting destructive neutrophils by way of C5a. And you might be saying, wait a minute, that sounds a lot like the type 2 hypersensitivities that come about when antibody latches onto tissue and activates complement, and they are actually very similar. But in type 2 reactions, the antigen that the antibody recognizes is native to the tissue being damaged. It's the circulating overreactive antibody that are a problem for those certain tissues that they recognize. In type 3 reactions, there is some kind of antigen around that is soluble in serum and will form complexes with antibody in the serum. But it's not the antibody binding which causes the pathology. Actually, formation of these complexes in response to foreign antigen is normal, and they're usually cleared by phagocytosis. There's only a reaction when the system is overwhelmed by excess antigen or if the complexes are too small to be handled by macrophages. They then can deposit in tissue and cause disease. This is a more widespread hypersensitivity associated with vasculitis and other systemic manifestations. Serum sickness is the prototype immune complex disease, which was first described when horse serum was given as an antitoxin to treat diphtheria, and it's caused by foreign-soluble protein antigens that form complexes with antibody and deposit in tissues. Usually there's a couple of weeks delay because, like we said, the complexes will at first be cleared by phagocytes, and a passage may say something like the patient was sick a couple of weeks prior and received some kind of drug, etc. People can get serum sickness-like reactions when exposed to certain drugs that contain antigenic heterologous proteins. For example, chimeric monoclonal antibodies, such as infliximab, a TNF-alpha inhibitor, are half mouse, half human. You can recognize a chimeric antibody because it will have an X in the suffix. Or, as we've discussed, antitoxins because the antibody comes from pooled plasma. This has also been reported to happen when patients are given IV penicillin, which can act as a hapten. A hapten is a molecule that can elicit an immune response when it's attached to a carrier protein such as albumin, and certain infections like hepatitis B can cause this as well, but this is low yield. The syndrome is a bunch of non-specific stuff and is self-limited. It will present as a fever, an urticarial rash, and deposits in joints cause arthralgia or joint pain. Usually there's an associated vasculitis as well caused by deposits in small vessels, and on pathology, you'd see fibrinoid necrosis and neutrophil infiltration. Nephropathy and diffuse lymphadenopathy are less common. An associated lab finding would be low C3 levels because it's being converted to its split products active C3b and C3a, and this explains why patients get urticaria because C3a is an anaphylatoxin, which causes mast cell degranulation and histamine release, and there will also be some other non-specific markers of inflammation like an elevated SED rate. The other weird example of a type 3 hypersensitivity is the Arthus reaction, which is not frequently seen in life, or the test for that matter. It's a local reaction caused by antigen introduced in the form of an intradermal injection that leads to complement deposition in the small vessels of the skin and complement activation. And there has to be a pre-sensitizing event, so it's not going to happen on the first exposure. It's been reported to happen with booster doses of certain vaccines, where obviously, since it's a booster, the patient had previously been exposed to that substance. The timing of the reaction is subacute, and there will be edema and induration within a few hours. It's quicker than serum sickness because the antibodies are already circulating. And the key thing you'd see on pathology is necrosis because of the deposits in vessels. Other more common examples of type 3 hypersensitivities are some of the complications of lupus. Lupus is tricky because the end organ damage that's seen can have several etiologies. Some may be classified as type 2, and in fact lupus is one of the most common causes of autoimmune hemolytic anemia, but many are type 3, and there will be complex deposits in many organs. Polyarteritis nodosa manifests as inflammation in the vasculature of visceral organs and has an association with Hep B antigen. And in post-strep glomerulonephritis, there is immunoglobulin and complement deposition in the glomerular basement membrane and mesangium of the kidney after infection with group A strep. In all these examples, the common denominator is reactive antibodies to some soluble antigen in the blood, formation of complexes, and deposition of those complexes in tissues causing inflammation. And there are many types of vasculitis and nephritis that are classified as type 3. Type 4 hypersensitivity is the delayed type, and by this we mean 2 to 3 days. It takes a little bit of time for T cells to be activated, proliferate, and produce cytokines for a cell-mediated response. And that's exactly what this is. It's a T cell reaction that does not involve antibody. Types 1 through 3, however, all do involve antibody in some capacity. And this is not limited to a single mechanism. It can be due to either direct cell cytotoxicity by CD8 positive T cells or T helper cell cytokine signaling that activates macrophages and a local inflammatory response. The examples of this can be remembered with the 4 T's for type 4: TB, touching, transplant, and T cells. The immune response to mycobacteria and some fungi is basically a type 4 reaction, and this also goes for the screening test for TB, which is the purified protein derivative, or PPD. The protein tuberculin is placed in the skin, which will cause a reaction in people that have been exposed to mycobacteria, including having had the BCG vaccine. If the answer is yes, they have been exposed, this will induce a Th1 reaction as TB is intracellular. Th1 cells will release interferon gamma, which causes activation of macrophages and a local reaction with redness and induration at the injection site. Induration, by the way, is firmness of the swollen area due to the influx of inflammatory cells. If there has been no prior exposure, then there will be no reaction. Tuberculin itself does not lead to a memory response because it does not induce the inflammation necessary to activate dendritic cells and the adaptive system. The reason PPDs take 48 to 72 hours to be read and be proclaimed negative is because even memory T cells take a little time to activate. On the other hand, a first-time exposure to TB will take more like a few weeks to get a peripheral response to the protein, and PPDs placed early after a possible exposure may yield false negatives and should be repeated. The second T, touching, refers to contact dermatitis, which can happen when there is contact with certain substances. The most common examples of this you'll see on the boards are poison ivy or skin sensitivity to certain metals like nickel. They'll either say the patient was in an unmaintained wooded area the day before, or show you the classic picture of a blistering weeping rash in a distinct linear distribution, as only one part of the patient's body had brushed up against the plant with the ivy twigs sweeping across their skin. And I've included a good example here. If it's a metal allergy, they'll show you a very well-circumscribed rash in the shape of whatever the patient had prolonged exposure to. Usually this will be on the wrist from a watch, or just above the waistline for a belt buckle. Just remember type 4 hypersensitivity, not your classic allergy. The plant oil urushiol found in poison ivy and heavy metals can act as haptens by binding skin proteins. On first exposure, dendritic cells take up the hapten protein complex and present it to naive T cells, sensitizing them. Re-exposure then causes an elicitation phase where T cells are massively recruited to the skin. This reaction is mainly cytotoxic, where CD8 positive cells induce keratinocyte apoptosis. Quite similar to the skin allergy test, where allergic contact dermatitis is suspected, a patch test can be used to confirm the substance. Diluted chemicals will be placed on small areas of the patient's back, and they will get a response in the area exposed to the substance at fault. Certain types of transplant rejection and also graft versus host disease are due to T cell reactions and are type 4 hypersensitivities. We'll be discussing transplants in further detail later in this lecture. And the last T is for T cells, because to test T cell function, we can use something called the Candida extract skin test, which makes sense that it would be a type 4 hypersensitivity if it's supposed to be testing for T cell function. It's very similar to a PPD, except getting a reaction and having a positive test is a good thing. You're supposed to have working T cells. Candida albicans is injected sub-Q, and we know T-cell immunity is very involved in the fight against peripheral candida. The body will mount a Th1 response, and macrophages will engulf it. If there's no response, we call this anergy. Now that we understand hypersensitivity, we can discuss specific reactions. Blood transfusion reactions also make great boards questions because there are 4 of them and they can test them against each other. It's a somewhat confusing diagnosis, which is likely what you'll have to figure out to some extent, although the answer choices may all involve the mechanism. The good thing is that they'll have to give you specific clues to lead you down the right path, and the details in the presentation of each entity can help you clinch the diagnosis. And you'll have to know a little bit about the pathogenesis of each. The one thing you really want to pay attention to in these questions is the timing, as that may be the first big thing to tip you off. These reactions all happen relatively quickly. It's not going to be days later. But allergic or anaphylactic reactions to blood transfusions are going to have an extreme temporal relationship because pre-sensitized cells are involved. Technically, it can be a couple of hours later, but the passage will probably say minutes to make the diagnosis abundantly clear. Anaphylactic reactions are all histamine mediated, and in this case, there is a type 1 hypersensitivity to some protein in the blood plasma. An example of this we already learned about is blood given to someone with an unsuspected IgA deficiency. These patients have never seen IgA before and must receive blood without it. The syndrome is going to be that of anaphylaxis, intensely pruritic urticaria, bronchospasm causing wheezing, vasodilation causing hypotension, potentially progressing to respiratory failure, anaphylactic shock, or both. The next type is the acute hemolytic transfusion reaction. This is the next quickest onset, hence it's acute, and will occur within an hour of receiving blood product, let's say after a trauma patient has already been stabilized and is on the way to the OR. And there is hemolysis going on, which is caused by antibody, and it's therefore a type 2 hypersensitivity. The most common etiology is ABO blood type incompatibility, where someone made a mistake and the patient got the wrong bag of blood. These reactions tend to be severe, and there is intravascular hemolysis as red blood cells are destroyed in the circulation by complement. If the response is due to other blood antigens, antibody coats the red blood cells and they are removed from the circulation by macrophages in the liver and spleen. This is extravascular hemolysis. These patients appear very sick, and there is a systemic inflammatory response, so they will be febrile and have hypotension, with resultant tachycardia and tachypnea. I don't know why, but flank or back pain is very characteristic. If you see anything about flank pain in a transfusion question, that's usually the clincher. If there is intravascular hemolysis, hemoglobin is not metabolized and will leave the body in the urine, so there will be hemoglobinuria, which gives urine a reddish-brown color. If there is extravascular hemolysis, heme will be broken down, and excess bilirubin can cause jaundice. Febrile non-hemolytic reactions are the most common and most benign. The timing is also the most variable, ranging from 1 to 6 hours, so that will not be your major clue. This is also a type 2 response, but to white blood cells or human leukocyte antigen, not red blood cells, so it's non-hemolytic. This becomes much less likely if the product has undergone leukoreduction, which is the removal of white blood cells. It can also be due to cytokines that build up during blood storage, which is why it's more common. Sometimes this just happens. The cytokines implicated are all the ones that cause fever, so IL-1, IL-6, TNF-alpha, and that's why it's the febrile non-hemolytic reaction. Otherwise, they will go out of their way to make the presentation very benign sounding, maybe with some other vague non-specific constitutional symptoms like flushing or headache. This is actually a diagnosis of exclusion, and most of the workup is to exclude more serious reactions. Transfusion-related acute lung injury, or TRALI, is exactly what it sounds like and takes the longest to manifest. It will be 6+ hours from the time of transfusion before you see any signs or symptoms. It's the only one that involves donor antibodies as the problem, and they attack pulmonary endothelial cells, causing inflammation and recruitment of neutrophils. Recipient neutrophils that are sequestered at the site of inflammation are then activated by other bioactive products in the blood, causing even more lung injury. This causes acute respiratory distress due to non-cardiogenic pulmonary edema, which just means the fluid in the lungs is not backed up from a heart-related problem like heart failure and is rather from an inflammatory exudate in the lungs themselves. The last topic we'll cover in this lecture is how the immune system can react to transplanted tissue, resulting in rejection. There are a few different types of grafts, and I included this just so you can recognize the terminology if it's brought up in a question. An autograft is a graft taken from the patient's own body. Examples of when you would do this is cutting down a saphenous vein for coronary bypass or taking part of the patellar tendon to fix an ACL. This obviously poses no immunologic threat because it's their own tissue, but the further away from self you go for the graft, the more likely the rejection. An isograft is also called a syngeneic graft because it's taken from someone with the same genes, which as of today means an identical twin. This is very similar then to an autograft. An allograft is any transplant kept in the species, so one Homo sapien to another, and this is the most common type of solid organ transplant. And xenografts are from non-humans. Sometimes we use porcine valves to repair the heart because pigs have organs that are around the same size as humans. So, transplant rejection. Again, these make great questions because there are 4 main types and they get tested against one another, so I like to take a similar approach as the transfusion reactions. Timing is again very important to make a board's diagnosis here, and actually the names of these are based on their chronicity, which makes figuring out which one it is fairly easy, but that means you'll also likely get tested on the pathogenesis and pathology. Hyperacute rejection sounds pretty extreme because the patient will still be on the operating table when the surgeon realizes the organ didn't take. The reason it's so quick is because the transplant recipient had pre-existing antibody to donor antigen, either from a prior transfusion or pregnancy, when many fetal antigens will be foreign to the mother. This is a type 2 hypersensitivity, and it's the only one that's type 2, and it has to be because there are no lymphocytes in the hyperacute setting. The rest of these reactions will be type 4. The antibody targets the graft vasculature, activating complement-mediated inflammation. As soon as the vessels are connected, this damage causes thrombosis and subsequent tissue necrosis. The passage may give additional clues by describing the fact that the whole organ will start to appear dark, mottled, and ischemic. And the only thing to do is remove the graft and get a new one, which sucks. Patient serum is cross-matched against donor cells to test for these antibodies, so this happens very rarely, but it happens on the boards. Acute rejection happens within weeks to months of the transplant surgery, and again, they're more likely to give you weeks to make the diagnosis unmistakable. Again, this is a cell-mediated response type 4 hypersensitivity where host T cells react to donor MHC, and there will be some level of MHC incompatibility if they weren't perfectly matched. The better the match, the less likely to have rejection. There will also eventually be a humoral component to this when T cells stimulate B cells and antibody production, but unlike hyperacute rejection, these antibodies are formed after surgery. The patient may present with low-grade fevers, signs of organ failure, and tenderness to palpation over the graft site. And a biopsy will show a vasculitis of the graft vessels and a dense mononuclear infiltrate in the interstitium. Remember, cytotoxic T lymphocytes are very sensitive to foreign MHC and like to target the vessels supplying the transplant organ. We send all transplant patients home with immunosuppression as rejection prophylaxis to prevent this kind of thing, but if they present an acute rejection, you want to give steroids to help reverse it and either increase the immunosuppressant dose or switch to an alternate maintenance therapy. And this is a path image from a lung biopsy proving acute rejection, and you can see there's a perivascular lymphocytic infiltrate. Chronic rejection is going to be a long time out, potentially years later, and most transplants have a shelf life. And this is due to a more indolent activation of T cell immunity. There will be cytokines released by helper T cells over time in response to being presented with foreign peptide antigens, which may include MHC. But if this happens over a prolonged period, the pathologic changes will all be much more insidious and more chronic sounding. So there will be arteriosclerosis of graft vessels from proliferation of smooth muscle as opposed to vasculitis. Poor blood supply will eventually lead to atrophy of the organ parenchyma as opposed to necrosis, and the hallmark is really interstitial fibrosis. Each type of transplanted organ has its own syndrome of chronic rejection. In the heart, there will be accelerated atherosclerosis. In the liver, there will be severe cholestasis and possibly something called vanishing bile duct syndrome, which is irreversible and requires retransplantation. One that is high yield is chronic rejection of transplanted lung, and it gets its own name, bronchiolitis obliterans. Years later, the patient will start to experience progressive dyspnea on exertion and a dry cough. On clinical exam, you'll hear crackles or rales due to fibrosis, and a pathognomonic auscultation finding for this disorder should make for a quick diagnosis if you hear it or see it described. This is the late inspiratory squeak, or some people call it a squawk, which basically occurs as the patient is trying to inhale through fibrosed clamped down airways. When they manage to pry them open, some of the trapped air makes a popping sound like a cork coming out of a bottle. So you'll hear a bunch of crackles, and then a pop just like that. Pulmonary function tests will yield an obstructive pattern. And the name of the condition comes from the pathology, where you'll see obliteration of small airways, or bronchioles. In the kidney, you'd see something similar. Chronic graft nephropathy will present like renal failure, with the patient experiencing hypertension, dropping urine output, and rising creatinine. They'll get checked out, and the transplant will be much reduced in size from atrophy, and a biopsy will show an obliterated vascular fibrosis. The last of the types of transplant rejection is actually the inverse, where the graft turns on the recipient and rejects them, and we dub this graft versus host disease. It's caused by cytotoxic T cells in the graft reacting to host cells containing quote-unquote foreign proteins, including MHC. This is usually in the setting of a bone marrow transplant, where there are many foreign lymphocytes being transplanted, and essentially our entire body is foreign to these cells. Anytime there is not a perfect match, there is some element of graft versus host. It can also be seen with liver transplants because the liver is lymphocyte rich. The timing of graft versus host is variable, but it can happen within a week. You won't confuse this with the others though, because the syndrome will not just involve one organ. There will be severe multi-system organ dysfunction. The skin is usually affected, and patients get a classic maculopapular rash that extends to the palms and soles and can become desquamating and painful. The endothelial lining of the gut is also under siege, causing ulceration, which will manifest as nausea, vomiting, and massive bloody diarrhea. And the third main organ that gets attacked is the liver, where damage to bile canaliculi leads to cholestasis and jaundice, and you can see cytopenias as well. There is a component of graft versus host which can actually be a good thing. If a patient is radiated for leukemia and then receives a bone marrow transplant, the transplanted immune cells will quickly recognize any residual tumor cells as being foreign and finish them off, especially since they may be expressing all kinds of weird cancer proteins. That's the silver lining here, and it's called the graft versus tumor effect. So this was a pretty high-yield lecture because it was based on clinical diagnoses, and those usually make pretty good boards questions because they're easy to write vignettes about. Just remember to focus on the specific clues in each category that will help you to figure out what the diagnosis is. In the next lecture, we'll discuss a few drugs that are used to suppress the immune system and their indications. If you like this video, share with your classmates and friends, give it a big thumbs up, and hit the pathognomonic icon to subscribe to the channel. And we'll be coming out with more videos on other high-yield boards topics, so ring the bell if you'd like notifications. And as always, please leave your comments below and tell us what we're doing well and where we can improve. Thanks for watching, and I'll see you next time.